Hello, my name is Victoria Chbosky, and I am a third-year medical student at Vanderbilt University School of Medicine. Driving is a topic that is very important to older adults given its huge impact on their independence and quality of life. Primary care providers should be prepared to address this topic with patients through performing a thorough driving evaluation and offering anticipatory guidance and referrals as needed. Older adults experience many changes associated with natural aging, including sensory, cognitive, and motor declines, which may impair driving skills. There is often public concern over older adults' driving safety. A retrospective cohort study from 2011 to 2014 in the U.S. and Puerto Rico showed age-adjusted annual fatal intersection crash rates were higher for drivers over 85 years of age than they were even for teens, the next most at-risk group. The fatal crash rate for adults over 85 was more than double that of the driving population overall. Interestingly, there were some safety factors more or less associated with fatalities in older adults compared to younger adults. Older adults were more likely to experience a fatal crash in the daytime, on a road with a speed limit less than or equal to 25 miles per hour, and on a two-lane road that was not divided. They were less likely to experience a crash in situations where no traffic control was present. And fatal crashes among older adults have significantly less of a predilection towards males over females, though males are still more at risk. The factors affecting older adults seem to have in common that they are related to decreased sensory abilities, and may also suggest older drivers are more cautious. This is a graph from the aforementioned study showing intersection fatality rate by the driver's age group. Interestingly, although adults over 85 are at highest risk for fatal car crashes, those 65 to 69 are actually at lowest risk, and the risk doesn't noticeably rise above that of the general adult population until age 80. This suggests that not all older adult drivers, especially those under age 80, are at high risk of fatal car crashes, and providers should avoid unfair negative assumptions about their driving ability. As I mentioned previously, the ability to drive is important for older adults' quality of life. However, studies have also shown that it is influential for their health. Shown in the table at the top of the slide, one systematic review from 2016 found that older adults who stopped driving had almost double the risk of experiencing depressive symptoms. A prospective study done the same year found that older adults who stopped driving were more likely to experience a decline in functional status, even resulting in decreased longevity, as you can see in the graph at the bottom left of the screen. Over 99% of older adults who continued driving were alive at 24 months, compared to less than 95% of those who had stopped driving. Given the great potential impact of driving or driving cessation on patients' health and the role of the primary care provider to give support and guidance to patients, it is evident that having conversations about driving could be very beneficial to the care of older adults. However, a recent study found that only 18% of geriatric patients had at least one documented discussion about driving with their primary care provider. Interestingly, the rate in geriatrics clinic was higher at 28%, while the rates for general internal medicine were 19% for hospital clinic and only 7.5% for community clinic, potentially supporting the idea that primary care physicians not trained in geriatrics are often underprepared for many aspects of the care of older adults. A focus group of physicians discussed multiple barriers to communicating about driving with patients, including external factors such as fear of legal liability when patients get in car accidents, and the thought that patients would get angry with the physician for questioning their driving. However, providers also acknowledge that some of the limitation is due to uncertainty of their role in patients' driving, and the lack of simple, easy-to-use tests or validated predictive screens. One of the biggest barriers is a lack of standardization in how to approach the topic of driving to older adults due to spotty, incomplete evidence on the impact of these actions. So, what is the role of the primary care provider in broaching the topic of driving with patients? The AAFP recommends performing driving evaluations for older adult patients, which are comprised of three main parts: careful driving history, medication review, and evaluating for medical conditions which may impact driving ability. A good driving history incorporates where patients drive, how often and for how long, as well as whether they have a history of crashes or near misses. It may be helpful to ask whether they've begun self-regulating their driving during times they don't feel as capable, often at night or in adverse weather conditions. If a caregiver or other family member is present, asking their perspective on the patient's driving ability may be valuable as well. Caregivers can also use the Fitness to Drive screening measure online, linked at the bottom of the screen, the results of which may help the physician to make appropriate recommendations for the patient's driving. Many medications may interfere with driving ability, especially those that have sedative properties such as opioids, benzodiazepines, sedative hypnotics, muscle relaxants, and some antipsychotics and antidepressants. Deprescribing these medications when possible can be effective to improve patients' driving safety. Additionally, it is important to ask about over-the-counter medication usage for causes of drowsiness, such as antihistamines, and also for NSAIDs, which one study found carry a 58% increased crash risk. It is also important to assess for medical conditions associated with aging, which may impair driving, such as neurological conditions like dementia, Parkinson's, or sleep apnea, or metabolic conditions like diabetes, heart disease, or cerebrovascular disease and prior strokes. Severe arthritis, especially in the neck, can also cause difficulty with driving. Once a primary care provider has finished a driving evaluation, they should consider whether their findings merit referral for other services. Many organizations, such as the AARP, have driving classes available for mature drivers. Some occupational therapists specialize in driving skill assessment and can test visual, cognitive, and motor skills before performing a road test. They can also recommend modifications of the patient's vehicle that could assist in the operation and safety of the car. Physical therapy can be helpful for patients with neurological issues such as Parkinson's or prior strokes to specifically work on regaining necessary functions for driving. The Knowledge Enhances Your Safety (KEYS) curriculum given by occupational therapy is an example of an educational intervention which may help older adults make safer driving choices to cope with vision changes. A 2017 study showed greater willingness to engage in self-regulatory behaviors to increase driving safety after implementation of the KEYS curriculum. For those who have had to stop driving entirely, early studies have shown some benefit to support groups for patients and caregivers. One study tested a psychoeducational intervention for older adults who recently stopped driving in order to enhance their community engagement and mobility. At 3 months, they saw more excursions outside the home, more walking, and greater use of transportation in the intervention group. A prospective study implemented a support group for patients with dementia and showed improved quality of life, fewer memory and behavior problems, and better emotional responses by the end of the intervention. Interventions for caregivers of patients with dementia have also showed promise, reporting caregivers had more confidence to handle driving issues. These studies are limited in their lack of long-term follow-up with patients, even noting after a few months that the initial positive benefits were not completely sustained, potentially suggesting the importance for long-term supportive interventions for older adults who have stopped driving. In summary, driving can pose safety risks to older adults, but not driving can have negative impacts as well. Therefore, it is useful for primary care providers to be prepared to assess patients' driving experience and to know what resources are available in their local community should issues arise. It will also be important in the coming years to fill in gaps of knowledge in this topic and standardize driving assessment, potentially including the use of validated screening tools so that this will become a more widespread practice in primary care. This is a list of studies I've referenced in my talk. Thank you for joining me in learning about the importance of driving evaluation in the geriatric population.